Hi everyone, my name is Amelie Fleury. I'm heading into my senior year at Holy Names Academy, and I'm super excited to be here so I can tell you all about the research that I've been doing here at SSF into the use of suicide gene therapy as a treatment to gliomas, and specifically whether or not we can replace traditional oncological treatments with it. So, for a little bit of context, what are we fighting here? Specifically, we are fighting the glioblastoma multiforme, which is a high-grade glioma, meaning it occurs in the glial cells or the glue of your brain. As you can imagine, these cells are all throughout your brain. There's not a crack or crevice they are not in. And that makes glioblastoma very difficult to treat because there are glial cells everywhere. Even when a surgeon goes in and takes out what they can see of the glioblastoma, there's still little bits of it left everywhere in your brain that can't be seen by a surgeon or even on scans. So one way that you can really think about this is imagine you're like cleaning your room and you think you've got everything, but there's like one sock under the bed. You can't see it, you don't notice it, and then you come back in like a month to do it again. You're like, oh my God, why is there 50 socks under my bed? Like that's what it's like fighting a glioblastoma. It just keeps coming back. And so that leaves it with an incredibly low survival rate. And it's very difficult to treat. The standard of care was pioneered with the STUP protocol, which is surgical resection and then very aggressive postoperative chemotherapy and radiation. And this buys patients on average about 15 months. But here's the thing. As I said, it's very aggressive chemotherapy and radiation. And as we all know, those are very difficult treatments to go through. For a lot of patients, 15 months isn't worth it to go through all the pain and side effects and suffering on them or their families. And in a lot of my clinical experiences, I see a lot of patients who elect to do nothing at all or enter palliative care. Especially I do a lot of work in veterinary medicine, and the most common reaction to the glioblastoma is euthanasia. Because for a lot of people, they just don't think it's worth it. And in my opinion, I think that there should be a better option. There should be something that does not leave people with the choice between life or quality of life. So, in better news, that leads us to suicide genes. So suicide gene therapy is a treatment in which, in a lab, scientists will code a specific strand of DNA and artificially introduce it into the brain. And this DNA will code for an enzyme that's just kind of left in the cancer cells. It's placed very strategically within the genetic sequence so that it's only going to occur in cancer cells. It's not going to occur in other brain cells. It's not going to start showing up in your liver or anything like that. And then what happens is a non-toxic prodrug is going to be introduced. So that's something that your brain is not going to red flag. It's going to get past the blood-brain barrier, get into the cells, and it really shouldn't do anything on its own. However, because an enzyme has already been introduced, as soon as it comes in contact with that enzyme, it turns into a toxin, inducing cellular suicide, hence the name. And the even better thing about this is it induces cellular apoptosis, which can be transmitted with the bystander effect, meaning if we all pretend this crowd is a cancer cell and we target Sophia, she's a cell who we hit with cellular suicide. The bystander effect means that we also take out Prisha and we also take out Arian and Zinnia and our lovely doctor in the front here. They all go too. So that makes it a really effective and very targeted treatment. And what's even better is studies have shown very low adverse effects. So it really is a treatment that can be a lot easier on patients. So the aim of my study is to determine whether or not suicide gene therapy is capable of being a wholesale replacement for chemotherapy. And my hypothesis is probably not. If a treatment like this was fully viable, FDA approved, I think everybody would know about it. Gliomas, and specifically glioblastomas, are one of the most deadly cancers out there. So if we had something that was pretty much a pain-free treatment, I think we'd all know about it by now. But I do think it's going to be an effective supplement, and we're very close to it becoming effective on its own. And my methods was a comprehensive review of the literature as well as several clinical trials. And I excluded trials that did not specifically talk about glioma cancers, as well as those that did not use the method we just discussed, which is called gene-directed enzyme prodrug therapy. There's other methods that fall into the branch of suicide genes, but I wasn't studying those. And also no pediatric studies. So these are all in adults. As I suspected, in isolation, we are not there yet. So this is a chart of all of the trials I was able to find since the 1990s on the use of gene-directed enzyme prodrug therapy. And as you can see, the vast majority are in phase 1. So these are trials that are pretty much saying we have a combination of enzyme and prodrug, and we want to just make sure that it works at all. And that's where a lot of the research is stuck in. And as you can see, phase 3 trials and phase 2-3 trials, which are really testing, is this safe? Is this more effective than what we actually have? Nothing's really getting there that much. And it's not really getting to FDA approval, largely because what we're finding is it's not more effective than the STEP trial. So they're looking for something that's going to buy patients on average more than 15 months. And we don't really have that yet. But as I suspected, we do know that it's effective because it's a really effective supplement. So this was a landmark trial in 2004 that a lot of research has been based on since then. And the red line is patients who had gliomas, and they were treated with the STEP protocol, so surgery, chemo, radiation, plus suicide gene therapy. The black line is people who simply received surgery, chemo, radiation, standard of care. And as you can see, patients who received suicide gene therapy survived significantly longer. You can see our difference in averages. They received suicide gene therapy 70 weeks, as opposed to the standard of care 39 weeks on average. And as you can see from our p-value there, very low, which means that we do know this is statistically significant and attributable to the use of suicide gene therapy. You can see there's also an increase in median survival time, so people were just out on the whole surviving longer. And this trial just happened earlier this year. It happened in 2023. And this graphs, it was 12 patients. And as you can see, several of them hit or surpassed the 15-month mark with the use of suicide genes. Not to such a degree that this was able to prove that suicide genes were more effective than the STEP trial, but roughly as effective. And what was really important is that no patient in this trial had a grade 3 adverse effect, which means, and very few of them even got to grade 2. So grade 3 is the worst kind of adverse effect you can have, and that's what we really think of when we think of chemotherapy. And patients receiving suicide gene therapy never reach that. So what we know is that when we're approaching this from the angle of what is ethical and what are patients actually going to want to go through to elect as their treatment, suicide gene therapy is really promising. And then finally, looking to the future, as I mentioned, a lot of studies are stuck in phase 1. And the reason for that is that with suicide gene therapy, you have a ton of different variables. It's a lot, and what a lot of failed studies have hypothesized is that we're on the right track scientifically, but when it comes to actually administering this treatment, getting it into the body, we're not quite doing it right yet. So this was a trial also in 2023, which was in mice, so very early on, but what they were testing is if you administer suicide gene therapy over a longer period of time, is it more effective? Because most studies do it one and done. They dump the genes, the drug, bye. This was saying if you do it over 3 months, are they going to do better? And as you can see from these scans here, that top group only received it once. And you can see pretty quickly on, the yellow is the glioma. It shows back up pretty immediately, whereas if they get it over 3 months, they're going a lot longer and there's significantly increased survival and time between recurrence, which is super important when you're talking about glioblastoma because its recurrence is one of the biggest problems. So in conclusion, we are not there yet in isolation. As much as I wish I could be up here and saying we have revolutionized cancer treatment, I can't say that. We're not seeing clinical trials past phase 3, and we're seeing that largely due to shortcomings in the way we're administering this treatment and kind of the recipe of it. There's still a lot of testing when it comes to the right combination of enzyme and drug that we need to look at, and there's a lot more variables that need to be explored in regards to how we're administering it. So that's going to require a lot more data in the future. But what we are seeing that's really great is because it's effective as a supplement, it can extend patients' survival past diagnosis when used in conjunction with traditional treatments, which means for a lot of patients, it might make that treatment more worthwhile, or it's just really showing us that we have promise. We're on to the right thing. And the most important thing, at least in my opinion, is there's fewer side effects. If we can really perfect our method here, then suicide gene therapy could be the reason that so many more patients are able to survive longer and get treated for these diseases without having to go through months of physical and emotional pain, which I believe is a huge consideration for so many patients and something that largely cancer treatment has failed to take into consideration. So this treatment is incredibly promising, and I'm really excited to see where this goes in the next few years. So these are my references. Thank you so much to everyone who listened, all the physicians who came out as well as supported me during my research in this. Thank you so much to Dr. Pierre for his support and his connection to research. And thank you so much to my fellow interns. You guys made this experience absolutely incredible. You were so supportive and encouraging, and this is the best experience. Thank you so much. Does anyone have questions?
Don't look at me, I'm an orthopedic guy. It's up there.
No, I think, again, you did an excellent job. I know this is a topic that was challenging because, as you said, there's not a lot of systematic reviews or studies, and some of this is still actively in clinical trial based. And I know you got a chance to connect with Dr. Bonham when he gave his talk on targeted therapy for low-grade gliomas. Again, and so, as you mentioned, there's a lot of great stuff for the future. And again, your future will be bright as you continue this going forward.
Yes, thank you so much.